Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Good day, everyone. My name is Zaundra Ellis. I am the Vice President of Hospice Professional Services here at Axxess. And today, we're going to talk about beyond the point and click, why am I here for, as it relates to documentation. And I am delighted to be presenting with my dear friend and colleague, Jennifer Kennedy. She is the Vice President of Quality and Standards at CHAP. I wanted to get that right. So Jennifer, welcome.
Thanks for having me. I'm always happy to talk with you. Anything talking about hospice, I'm in.
Same. And so delighted to have our guests joining us today. Everyone is muted, so Jennifer and I are going to hop right in. So, we know that the hospice industry is under such intense scrutiny. Some places we're lacking a little bit, we're missing some big things, and other places it's overbroad and overreaching, and really causing a lot of problems for hospice agencies. So, it's easy to go to the Medicare Administrator Contractors website and see, their top denial reasons, right? And a lot of times those are technical denials, right?
Right.
So, yeah. And so, there's a lot of operators, big and small, are really looking at those elements that have to be present, right? How do you think that's really affected the art and the attention of actual documentation, the narrative documentation in the notes they're sending?
So I think the technical stuff is just that. It's technical, do you have all the elements on your election statement? Are all the pieces of your certification of terminal illness there? Those items, I think, are not the same as the quality of clinical documentation that tells that patient's story and that patient's family or caregiver's story. So I think when we talk about documentation, we have to think of it in two different ways. We have to think about the do I have all those pieces there that the regulatory text tells me I need to have there? And that can easily be, pre-audited, if you will, as a part of your quality and compliance initiatives. We want to be proactive rather than reactive. It's great to find out on your own what your gap is before you have a MAC saying, hey, you know what? You've missed, you didn't have this piece of your CTI, and you're going to have to, and none of these benefit periods are now valid, right? So now you have to pay us about X amount of dollars.
Yeah.
So I think, it's like part of your pre-bill audit, if you will, right?
Yep. If you miss it, it's devastating, right?
Absolutely.
Yeah, absolutely. So, I think one of the things that's really, what you said a moment ago is really super important, right? About telling that story. And a lot of times when we think about documentation to support hospice or continued hospice eligibility, we think about the CTI, obviously, right? We think about the nurse's narrative documentation. Let's talk to me a little bit about how other members of the IDG can come in and help support that eligibility and really spread the pressure out a little, right? So it's not just the physician and the nurse.
Right. It's everyone on the hospice team's responsibility to, assess. Maybe assess isn't right. Well, maybe it is in a way. Is assess and support eligibility. So yes, we're admitting a patient to hospice. We're assessing eligibility. Yes, and then they're on every visit, no matter if you're a nurse, or a social worker or a spiritual counselor. Everyone has their set of assessment expertise, which they can apply to, really looking if the patient still meets criteria. So yes, a nurse is looking at all that physical stuff, and a social worker also can be part of that piece of the puzzle in bringing their assessment information back to the table to say, okay, what do we think about this patient? Do we update the plan of care for the next 15 days if we're sitting in an IDG meeting? It's not a nurse's responsibility or to determine if the patient is still eligible. It's, yes, the physician has a big piece in that, but it's all the information everybody brings to the table that helps determine eligibility. And that should be happening not just every 15 days. You should be asking that question as an IDT member every time you go out there. I brought Mrs. Smith, or we brought Mrs. Smith onto hospice for this. Is that still true? That's where you're looking at progress towards goals. All of those things come together to make that determination or support the continued determination of eligibility.
Yeah, so I love, I'm not a nurse. You've heard me say before, I play one on TV. Just kidding, But anyways, I know enough to be dangerous. But I think, it's really, I'm just going to say it's super important to draw, maybe to consider the non-clinical IDG members into that discussion of eligibility and responsibility, right? For ensuring that we're portraying an accurate picture of that patient, because we're responsible for caring for the patient and their loved ones, right?
Right. And even though there's no regulatory requirement to document decline, right? We know this, but the Medicare administrative contractors are looking for that in documentation. So I think, that's really a key piece where all IDG members can be looking at the patient in their respective perspective and seeing, is the patient declining? Anyone, not just a nurse, can look at a patient and say, I think you're losing, or they're losing weight, if they can't get on a scale and be weighed, right? Are their clothes baggy? Are they eating less? And if the nurse is only going a couple of days a week and we have an aide going in more than that, we can absolutely instruct aides on things to look for markers of decline. Same for social workers and spiritual care counselors.
Yeah, I agree wholeheartedly. And I think we want to provide care to people who are hospice eligible. And I have long said, and you may have heard me say this, I think that it's cruel to admit someone to hospice services or keep them on hospice services when they don't meet the criteria for hospice services, right? Because in essence, we're saying, hey, we think you're going to die in the next 6 months. That's not true. And I know that there are some, bad actors out there who exploit that. But I think having open conversations amongst the IDG with your organization's leadership, so we don't get in those situations of, well, you're just trying to keep that patient on because, we have to grow. And I'm not saying, well, you want to keep the patient on because you really love them and they're going to lose their aid, their DME, their medication, so there's always the opportunity for those things to overlap when we're talking about hospice eligibility. And I think you do a wonderful job of explaining like how that works and the value of transparency and commitment to one another.
Yeah, and we do have that responsibility of taking care of patients who actually, fit the criteria, and we take care of them to their last breath. But as we know, I think the last quoted, this was probably 2 years ago that CMS included this in the payment update rule, was that the live discharge rate was still hanging around 17%. And of that 17%, the highest percentage was no longer eligible. That was the reason for discharge, right? We know that individuals can come to hospice, and because of consistent care management, they may have a disease plateau. And we, watch that carefully as hospice providers. And if we see a sustained, no decline in the sustainability in the disease trajectory, we have to. Medicare regs say you have to discharge. But that doesn't mean that we don't do good discharge planning to make sure that patient leaves hospice with the support that they need. My personal opinion, Zaundra, is that after a patient is discharged, whether it's from hospice or from home health, if they've had that jagged in and out of the ER hospital trajectory, it would be great if there were a palliative care benefits that they could be in, right? But we don't have that. So we have the responsibility as hospice providers, as home health providers, to do really good discharge management and planning so that they don't fall into a huge gap of non-care once they leave our service.
Yeah, I mean, I think we were talking a few minutes before this started about, the home health proposed final rule that was published earlier this week, and, really how devastating it would be if it's finalized as in its current state, right? And how, more people are going to lose access to care, which is already stretched, right? Because, staffing concerns, I mean, it's hard for patients to get admitted sometimes, even in very urban areas, and in the outlying rural areas, it's almost impossible, and I think patients or Medicare beneficiaries, patients just in general, people, they deserve care when they need it.
Absolutely.
And kind of going back to, the whole, well, we're just keeping this patient on because we got to hit our census numbers or whatever. I mean, I think it's important for everyone, but, non-clinical leaders maybe to think about, yes, you want to hit your numbers, right? Nobody likes to get called into the principal's office and you have to explain why. But if you use the explanation of why at the beginning with your staff, and they understand that if, we discharge a patient, if they get to graduate from hospice, that means that we can take care of one more, so
Absolutely.
It's for someone else.
Right. I think hospice providers really need to just look at how they operate. We know there are the players out there at day 100, or rather 179 days. They may just say, okay, goodbye. We don't want to take a lesser rate, or I'm sorry, a day. You know what I'm talking about, the 60. Sorry, I was thinking longer. At day 61, they're saying, okay, we don't want to take a lesser rate for your care, so we're cutting you loose. I absolutely think that's irresponsible. Now, let me hop back to the 180 because I had two thoughts in my head going at one time. When we have patients that hit that 180 mark and they're still with us, that's when it really becomes extremely important that you up your documentation game. Okay, you absolutely can have patients that are eligible with a long length of stay, but you have to just be able to show that in your documentation. It's very difficult, particularly with dementia or Alzheimer's diagnoses, where they're just declining like a millimeter at a time. But you have to think of documentation strategies that you can utilize. And And this is really, looking to your medical director, your hospice docs, to help with that documentation so that that patient doesn't lose the benefit that they are entitled to, right, until they die. So it's very hard. The climate is very hard right now for providers, and even I'll even say for patients, because if they're not dying within a short amount of time, if they're not dying before that 6 months is done, then many times they're leaving. They're being pushed away, pushed on out of the benefit. So, and I think, Zaundra, if I don't want to go down a rabbit hole here, but I think the benefit is not designed for today's healthcare landscape and today's population and their needs. This is a benefit that was designed in 1983, and it's not really evolved very much. So something really needs to happen in order for it to serve today's patients and their needs. Because this is 2024, how many years after the benefit was originally designed?
Yeah, I think that's important, and I hadn't really thought about it. But the benefit started in '83 when my dad died in July of 1986.
Yeah,
had cancer. He had hospice, and it was completely different, than what we see now. Yeah, I mean, they came in and it was maybe it was much less regulated, right? But the focus really was on him, right? And they didn't have the distractions of all of the regulatory compliance issues that we see now, and we should be held to a standard. I'm not saying we shouldn't have those, right? And, modern medicine, and how people are aging differently, and they're dying differently than they used to. And I don't think that we can get back to 1983 or 86 ever again. I think I think providers need to be agile, and they need to be asking the questions and not reading like what's coming out and saying, oh, we can't do that, and try to be creative. So
yeah, absolutely. Providers have to be nimble. I mean, we have the benefit, it is what it is. There have been little bitty changes along the way, but providers have to function within that framework. And, it doesn't work for everything and everybody. This is what we have. Eventually, we will be a pay-for-performance model, and I would hope or guess that there would be modification of such things as criteria, length of stay, all of these different things. But right now, providers are just trying to run on that treadmill of regulatory compliance with all the audits that are out there, all of the focus of program integrity on hospice. So it's a really difficult climate to be a hospice provider and not lose focus of why you do what you do.
Yeah, exactly. And I think about different conferences, that you and I have been to, and over the years, and how great it is to see hospice providers really get together and talk and collaborate, those side conversations that happen. I think, in a world of scrutiny that hospices are operating in right now, I think those connections are really important, even, locally, because when everybody works together, what we do is better. So
absolutely, yes.
Yeah.
And I think, I know it's so competitive out there. I understand that it's a competitive marketplace. People are, or rather organizations are competing for patients, but in some ways, we've got to lock arms and we have to share best practices in order for sustainability of established hospices and those hospices that are truly opening to satisfy access difficulties, to help mentor them to be the best provider they can possibly be.
I love that you said, be a mentor. You're so good at that. I was thinking it helps us weed out kind of people who may not be in the business for the right reasons, right?
Right.
There's been lots of news and information, and bad actors, and I think people need to realize that sometimes these folks that are bad actors, they're right under our noses. Like they're hiding in plain sight. And, by having conversations and developing those relationships, I think that is a way that providers can kind of take things into their own hands. Not that they want to go sneaking around and look through trash cans or anything and find out about their competitors, but really just have that conversation about hospice and why they're doing hospice, because they could borrow staff from each other with contract. There's lots of things that they could do to lock arms to make things better. So so let's talk a little bit about let's get back to documentation.
Okay.
Before we get in the principal's office. So you talk a lot about using your eyes and ears, right, to support your documentation, to create your documentation. So can you give some examples of that? What are we hearing? What are we seeing? What should we be looking for?
Yeah, absolutely. We've got to, as providers, go beyond point and click in EMRs. Absolutely have to go beyond that. Yes, I love the ideas of EMRs, but independent or objective reviewers of documentation don't see individualization. If a clinician is just using the point and click and they're not free texting additional information about what they saw beyond checking a box, what maybe recording a subjective comment from the patient or a family member on that particular visit. So, for example, I think I'm a vintage nurse, so I grew up with the SOAP note, right? Subjective, objective, plan, yes, SOA, assessment and plan. Okay, so we always had to capture subjective comments in our documentation if we were using a SOAP note. A great example would be is if you have, let's say the patient is Mr. Smith and Mrs. Smith is his caregiver, and we ask Mr. Smith, how's it been going since I last moved here? Oh, everything is good. I feel pretty good. And then Mrs. Smith says, no, he's been sleeping more. He's not been wanting to get up to watch his favorite show in the afternoon like he has been, about a week or two ago. That's really important information that I can capture and put into my clinical note. It gives me a different perspective than just, oh, I'm fine, I'm good. Everything is good, So
yeah.
It's really, I think it's important, to have those conversations with caregivers if they are there in a visit, to say, is there anything else that you're seeing? And just have those conversations and collect that data and get it into the note.
Yeah, so I've heard you speak before, about higher level thinking, right? Which kind of goes hand in hand with, beyond the point and click, right? So that higher level thinking and that higher level problem solving, how do you see that in action? How do you do that when you're a hospice nurse?
So, I just did a podcast with Kate Jones, and she is a longtime nursing instructor, and she happens to be a CHAP board member. as well. And we were talking about getting away from that label of non-compliance and using the 5 whys to really get down into the weeds of figuring out why something is happening or why something is the way it is. And I think that's a really great strategy, not just for nurses, but everyone on the IDG is, you know, for example, I see that you didn't take all of your medication, if I'm a nurse. Why didn't that happen? I just didn't. Well, you know, you need to go beyond that. You just don't document patient didn't want to take the medicine. Is there another reason? Was there distraction? Was there something else happening in the house of why the patient didn't take the medicine? Is the caregiver usually the one that gives the medicine and they give the patient the medicine? So I love that idea of the 5 whys, of trying to dig down just a little bit deeper into why things are the way they are. It's like a little tiny root cause analysis, you know, yes. Which, you know, can yield some really great information about why things are they are, or if a patient is not adherent. I vowed never to use the word non-compliant anymore since I had my conversation with Kate, is you know, why they're not adherent to the plan of care. So I think everybody needs to be using that 5 why strategy.
Yeah, I love what you said about being adherent to the plan of care, right? Because, you know, one of the elements of the plan of care is that you coordinated with the patient when possible and their family members, and you document, you know, whether they're in agreement with it or they want changes or what, you know. And I think that maybe we don't think about that step, you know, when we are making that visit. I mean, maybe reviewing that plan of care with the patient and their loved one to see what's working and what's not working. Right. Have a conversation and really have that patient-centered, individualized plan of care.
Yeah, it's their plan of care. It's not mine. It's theirs. You know, it's theirs and you know, their caretaker, their family. So they should be the driver. And I think that hospice providers do a good job of saying, how do you want this to go? What are important things to you? But they may not ask it every time they go. What matters to you, Zaundra? What matters to you today? Has anything changed since I was last here? Because depending on what's happening with a patient and their length of stay, what mattered to them last week very much may have changed to this week. And we need to be responsible to make sure that what matters to them, we support, we put interventions in place to get them to the what matters. So if my patient loves her dog and she wants to be able to walk out into her backyard with her dog every day and sit in a chair under a tree and watch her dog run around, then I need to make sure I put interventions in place to get there. If she has strength issues, then I'm not going to be afraid to get a PT in there for a couple of visits to teach her and her caregiver how to do strengthening exercises. So I think we're, again, hospice providers running on that treadmill so quickly, they may not say, okay, well, we do have PT that we can put in there. Or for some providers, I'm not going to do it. It's going to be hit to my bottom line for my per diem, right? But then we're not actually developing a plan of care that is a patient's plan of care, are we? That correct. What matters is the bottom line of every hospice visit. And that's, you know, that's the way we should provide hospice in a compassionate, optimal way.
Yeah, I think kind of sometimes we say, okay, well, just put yourself in their shoes, you know, but I think it's more than that, right? It's more, how do you feel about questions, right? Have you thought about, or can we talk about? Because, you know, with hospice patients, things can change in a second, right? You know, there are family members maybe that have shown up they haven't seen in years. Maybe they got into a big old knockdown drag out, or maybe, you know, it's the person they've been waiting for, you know,
Yes.
kind of really understanding, you know, it's not just a response to physical medicine that we're measuring, right? But we're looking at the patient in their entirety and asking responsible questions to elicit answers to help us ask the next question.
Yeah, I think you're absolutely spot on. You know, when we look at hospice as a holistic entity, right? You know, there are different types of strife and pain. It's not just about physical pain. It's emotional pain, it's spiritual pain. So we've got to, again, as holistic care providers, hit all of those marks and ask all of those questions to do the proper assessment so that we can figure out what interventions we can do with that the patient is going to be okay with. So yeah, it's more than that. It's more than just getting a PT in there to get you out to see your dog play in the yard. I mean, that boosts her emotional well-being, perhaps her spiritual well-being, and all of those things that go with it. So there's so much more, and that's really where that teamwork and critical thinking comes in. Is, are we doing all we can do? Have we asked the right questions? Are we continuing to ask the right questions as the service period progresses, so that this person gets to their perfect end, or the most optimal end that they can achieve?
Yeah, so I think, you know, the IDG, you know, we've all seen sitting in a group, we're talking about the patients back in the day, you know, passing papers around and stuff. And I think it's easy to see the IDG just as the IDG instead of the cross-functional team of experts that you have sitting at the table, right? And, you know, that includes, you know, could be volunteers, could be, you know, the hospice aides that provide all the care, the attending physician who maybe has known the patient forever. You know, I think it's important to draw that cross-functional team together to really have the best understanding of, you know, the patient. I had a patient once, the aide came back to the office, I was there, and she had been to see the patient, and good news, his daughter is here from California. You know, everybody's excited, oh, that's great news. And she said, yeah, but she brought a big bag of pills for the patient. Excuse me? Yeah.
Oh boy, oh boy.
Yeah. So, you know, but it was so important that that aide knew that she was part of a larger team, and she had the confidence to say, hey, we got to do something real quick because, you know, I don't know what's in that bag, but somebody needs to go check it out, you know.
Right, right.
And
And
so
that's what interdisciplinary is, isn't it? Yeah.
yeah, I mean, it's just right at the foundation of what we do or should be. You know, where, you know, everybody's voice is valued and heard, right? Amongst the team and amongst the patient and their loved ones. So, you know, I think that really, you mentioned it earlier, it's the patient's plan of care. You know, if they're able, let's sit down and talk about it, right? And if you're working with, you know, a sweet gentleman and his wife isn't in agreement with what he wants as far as the plan of care, you know, that's a great time. Let's talk about this now, right? And you solve two problems right there. So, you know, how do you how do you make it easy for caregivers, loved ones, family members to really get involved in the conversation without letting them take it over if the patient can speak for themselves?
Yeah, that's a delicate dance, because it depends on the family dynamics. It depends on the patient's capability, when the patient is admitted to hospice. There's so many variables that have to be considered. But, I think it's the responsibility of every team member to say, if the patient cannot participate, speaking to the right person who has the ability to speak for that patient. Not the, if the patient is a wife and her husband has the medical power of attorney, then that's who we listen to. We're not listening to children. We're not listening to family members who are squabbling about what mom wants and they don't like it. That those you have to speak to that, but that's distraction from really forming a plan of care that meets that patient's wishes. And even if you have a patient that can speak, many times they're overridden by their family. So we need to make sure that we're meeting the patient's wishes and doing that counseling and boundary setting with those family members. So here's, I think our social workers are untapped gold, and they can do so much more than funeral planning and placement planning. These individuals went to school to be social workers with counseling as a part of that. So I think we need to harness the specialty of social workers more than we have in the past. So, and then we have the new regulation of having the option to add a marriage and family therapist or a mental health counselor as needs dictate. But I think we can utilize our social workers to a greater extent to help the team stay on track to meet what matters and what the patient's plan of care should be per the patient.
Yeah, I love that, and with the new regulatory guidance for marriage and family counselors and mental health counselors, I thought it was interesting the way CMS said, okay, well, these guys are counselors, but the social worker is a case manager, right? The counselors don't necessarily have that skill. So CMS pointed the finger and said, hey, in my mind, the social workers have everything that you really need. These are extras over here that can supplement, but not replace the social worker. And you're absolutely right. I mean, social workers, they do so many things. People are like, oh, well, they're always in the office, or, I'm like, well, they're making phone calls and trying to solve problems, real problems for real people, and not everyone is good at that, and not everyone is trained to do that. And so, social workers are magic. They're the magic of the team.
They are. And, I would hope that hospice could get to a place where we could see a difference from care plan or plan of care from plan of care other than social worker one time a month. Seems to be the standard scope and frequency because their caseloads are so high.
Correct.
And you know what, Zaundra, I get it. I understand. I've been out there 2 feet in a hospice, and I understand the staffing challenges and everything that hospices, the pressure that they're under. It is, when we're talking here, we're talking, what would be optimal. And you have to take whatever piece of this that we're talking about to see if you can bring it back to your hospice and implement it. within the constraints and variables that you have, because nurses are hard to find, social workers are hard to find, aides are hard to find. I get it. But if you think that you want to give really great care, maybe you don't take as many patients as you have been. Maybe you shrink your census a little bit and up the quality of your care. I don't know, just an idea out there. And I'm not a business or financial person by any means, and you'll probably get many complaints about that. She doesn't get it. I do get it. I do get it. It's just another thought. If you want to be a leader of quality in your community, and you want to free up social workers to actually be counselors, you have to let them do that, and that means that they're not serving 60 patients on a caseload. You know what I mean? So
Yeah.
we have to figure out the balance of all that as individual providers. What works, and what's your true north? What do you want to be out there, and how do you want to prove your quality beyond your CAPs and your HIS scores and your claims-based measure scores? Those are things providers need to figure out in today's landscape.
Absolutely. And, you're spot on, right? When you think about, when you talk about, growth or size and opportunity, for hospices and communities. And, I think providers really need to see the bigger picture and look into the future. Hope is no longer on the horizon. Hope is here, right?
It is.
To me, it looks a lot like the Oasis. And now we know, home health organizations are gathering that quality now, and they're going to be paid according to those measures, right? So,
Correct.
That blow and go kind of mentality for hospices, if we can take a step back and think about retaining our staff, because we're not working them to death, right? We're not having to pay orientation, overtime, and our quality scores go up, and people do look at Google reviews first, and then they look at the CMS Care Compare website, right. But they're out there and they're looking to see. If you could change that narrative, your online reputation, you can grow in a meaningful way. So, I have always said growth as an operator, growth is wavy, right? You're going to have peaks and valleys. You're going to have, we admitted 5 patients, and then 7 died, and then 7 more died, and then you're going to it's like a roller coaster, right? And I describe it that way, and I say it's not like climbing a mountain. It's not.
No.
And I think, with all the data that CMS and regulators have, other regulators have, they can tell, who's continuing to grow without any, expected dips. And so I think being mindful of that and being of service to the people who need you the most, as an operator, that includes your staff, being of service to them, to ensure their quality of life as well, to the extent you can. It's a win-win if you can take a step back, see the big picture, and look at the state in the future at the same time. So there's just so much out there, and we have flags that are waving, saying, "Hey, look over here, with our friends and colleagues in home health." Honestly, we got to be taking the time to pay attention.
Yeah, we do. Leaders of hospice organizations have to be thinking 5 years, 6 years, 7 years down the line, when most likely we're going to have a different payment model. Okay, regulations may be skewed a bit. The COPs, I think, will stay the COPs, but there are other regulations around hospice that could possibly change. and how you're going to function in a pay-for-performance environment. So quality is everything. It's, yes, compliance is important, and you have to be compliant and to federal regulations, state regulations, if that's something that applies. But you have to think about how you're going to raise the standard of your practice so that you can achieve the best quality possible.
Yep, I think it falls in line with, take credit for the good work that you're doing, when you're
Yes.
document all of that, write that, include that in your notes, include that in your IDG notes, your meeting notes. So quality becomes, so if you meet the regulations, right, the COPs, you're operating at the baseline.
Absolutely.
Right? And the same thing for, hospice quality reporting program. If you're meeting that standard, but you're not, we don't want to be operating below or at the baseline, right? We want to be operating above all of that. And it takes the entire team to do that.
It does. That's what's going to make you distinctive in your marketplace and your community.
So we've talked a lot about a lot of things, and I'm so grateful for your time. I'm not letting you off the hook yet, but I do want to talk about the aging workforce in healthcare. None of us are getting any younger.
No.
We've got lots of millennials. I feel like I'm pretty tech savvy. I always have been. I kind of dig it, but I know a lot of people are not. How are we going to begin to address, bringing millennials into the hospice world to work?
I think it has to start with their education, whether they are going to nursing school or they're going to be a social worker, whatever their baseline health-related education, that has to be, the whole continuum of healthcare has to be built into it. So I think palliative care should be a topic of learning, as well as end-of-life care. I think maybe I had about 5 minutes of end-of-life care education back in the day when I was going to college for nursing. So I think it has to start there. And then, once they come out and work in whatever respective area they're going to work in, that's where we have a huge gap. Because even now, acute care providers, anyone outside of the post-acute realm, or even at the front of the post-acute continuum, still doesn't understand what hospice does, and the benefits of it and timing and all of that. So we're never going to make good progress in acclimating all care providers, whether they're older or younger, unless there is some kind of incentive to understand all of the things that are available in a continuum, including end-of-life care. So we, as hospice providers, have a lot of work to do with that continuous education, but I think it also has, there has to be some onus upon Medicare and the federal wonks to take a better enforcement of that as well. So if they want to save dollars, if they want to decrease rehospitalizations and et cetera, then there has to be better incentive in that realm for that to happen. Meaning, it's not just a measure that's going to change behavior, Zaundra. There's a hospital measure for 30-day readmissions, right? A measure isn't going to change that. There needs to be a different methodology to change providers outside of hospice to get them to embrace what hospice can do and when's the right time to send someone on.
Yeah, I think about so many young nurses, they go in the hospital, a lot of them, they're working in labor and delivery. That's what they're doing, right? And you learned a lot about labor and delivery, did you, when you were in nursing school? Yes.
I did, and I actually was a level 3 NICU nurse for many years. So
yeah, but
went into that, yeah.
We don't spend time like explaining, the death process and, all the things that
Oh,
go
God,
with
no.
it, hospice, right? Because we're in it to win. We don't want our patients to die. And that makes sense, but you're spot on with the education piece. Like if it was a required element of nursing curriculum, I think that it would make a huge, huge difference with the workforce that we have. People can see it in a different way. I was on a call earlier this morning, and it's two sacred times in life: when you're born and when you die. And they deserve the same attention and value. So yeah. But I think it's incumbent upon all of us. The Petite Act is out there. Contact your federal representatives. Make sure that they know that you support it. Look at what's going on in your state. I mean, Texas has a nursing shortage agency, which is wild because they've got nurses that are measuring the shortage of nurses. I'm like, y'all want to go see some patients? I'll do the.
What can you do?
I'll count the numbers, but yeah, I think it's interesting. So we're almost to time, and I love what you said about what is important to you today. And I just have one last little thing that kind of ties into that, right? We can't necessarily ask that question to a hospice patient if we've been told not to use the H word. And it happens, right? And you're looking at a patient who clearly is hospice eligible. I think about a 21-year-old patient. That was tough. She had cancer. Yeah, but don't use the H word. And I actually went on the visit. And so, I mean, how do we overcome that? What are your words of wisdom about don't use the H word?
Oh man, I've been down that road many times. And usually my response was, and it's the family who are saying don't use the H word, right?
Right.
Is, if the patient asks me what I'm doing here, where I'm from, then I'm going to be honest with them. And you have to do your due diligence of counseling with the family members, the caregiver as well. You're working sort of that side of the fence. But I've always said to families that I would be open and honest with the patient if the patient was going to ask me questions. And it just takes time. Sometimes coming to hospice is a very quick process. You're going from, I'm going to be taking my dad to his next round of chemo, and we have an oncologist saying, well, I'm sorry, there's nothing else we can do for you anymore. Here's your hospice referral, right? So sometimes those transitions are very quick, and people, particularly family members or even patients, haven't made this sort of transition in their emotional well-being or their brain. So I think you have to respect where they are, but you also have to be honest if questions come up.
Yeah, I love that. Really respecting where they are. It's probably not the patient's best day or their loved ones, right? And so, we need to be of service to them as quickly and as transparently as possible. I talked earlier about it's cruel to tell somebody that they're hospice eligible when they're not. The same could be true on the flip side, not being honest with the patient who really wants to know what's going on. Why are you here, right? Go back to the question. Why are you here? So we've got a couple of minutes. Jennifer, what parting words of wisdom do you have for our hardworking hospice folks listening in today?
Well, I would say be compliant and do the right thing. When you're doing the right thing, you're elevating your practice above that, what we talked about, that base regulatory level. And, maybe doing the right thing may cost a couple of dollars. Maybe doing the right thing will, excuse me, cut a staff member's productivity down for a day. But if it's what the patient and family need, do the right thing.
Yep, I love that. Do the right thing and the business will follow. So Jennifer, I appreciate your time today and sharing your valuable insights. I could talk with you all afternoon about this, but I'm going to let you go about your day. Thank everyone for joining us. Have a wonderful weekend, and we'll see you next month.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.